experience in target delineation in breast cancer. So there are available atlases for contouring breast. First, RTOG, which is issued in 2009. Astro ProCap 2015, and there is some updated modification in 2016, and the Labrador in 2015, by RTOG, and the RADCOM. So this is a study comparing between photon and proton, and it's released in 2015 as well. But all of these, I assume that RTOG is the most popular one. So these are characteristics of each atlas. RTOG, TROG, and the RADCOM, usually they use bony and muscular landmarks for contouring, and most of them use for locally advanced disease, especially RADCOM and TROG. But for the ESRO guidelines, the most different thing is they based on the vessels to determine the target volume, and usually used in early stage of breast cancer. So you can see that the ESRO guidelines volume usually smaller CTV comparing to other atlases. So why ESRO use vessels based? Because there are some drawbacks of using bony and muscular structures. For example, the target volumes change with different treatment positions, like arm positions and patient's anatomy. And also the volumes increase in comparison to treatment volumes in the 2D era. And the third one is there is often no anatomical relation with lymphatic system. Usually it would be related more with the vessels. So all the boundaries I'm going to talk about today, it includes regional lymph nodes, supraclavicular fossa, axial lymph node levels 1 to 3, internal mammary lymph nodes, and the breast and the chest wall. So we're going to start with supraclavicular fossa. So I start with RTOG boundaries because I'm sure that everyone used to using these kind of volumes. So the border and the boundaries are here of only supraclav field. The cranial border, we use caudal cricoid cartilage. And the caudal, we use caudal clavicle head. The anterior, we use sternocleidomastoid muscle. The posterior, we use anterior skeleton muscle. And the lateral, they are cranial volumes and caudal volumes. In the cranial volumes, we use lateral edge of sternocleidomastoid muscles. And the caudal, we use junction of the first rib and on the clavicle. And the medial one, we just draw it and we exclude thyroid and trachea. So let's talk about the difference with other guidelines. So for supraclav fossa, for ESRO guidelines, they don't call supraclav field, they call lymph node level 4 because they think that supraclav volumes of the breast and the head and neck is different. So for the breast, they use another word. So they use lymph node level 4. And as you know, ESRO guidelines, they use, it's based on the vessels. So they use 5 millimeters add on to subclavian vessels. So these are right subclavian arteries and left one. So they use 5 millimeters above these vessels. But they have some remark that if the patient presented with N3, you should add 1 to 2 centimeters to the lymph nodes. So for RTOG, RADCOM, and TROG, they all use the same of cranial border, caudal of cricoid cartilage, while the ESRO, they use 5 millimeters add on to the vessels. So when you see the cranial border, the RTOG cranial border is more superior to ESRO. How about medial border? So medial border for RTOG, RADCOM, and TROG, they include internal carotid artery. They just exclude trachea. But for ESRO, you can see that the medial border is at the medial of internal jugular vein. So it doesn't include internal carotid artery. For lateral border, mostly the same. For cranial volume, they use lateral sternocleidomastoid muscles, and the caudal one, they usually connect to axilla level 3. But for posterior border, for arterial G, it's a bit short, so it's at the anterior scalene muscle. But for other lateral border of levator scapulae and pleura. Also, the volume that's called posterior neck volume, which is an optional one, and it's because it's related to the recurrence pattern of the previous studies that are some lymph node recurrence in this area. So the posterior neck volume basically connected to the superclav volume and extend posteriorly to trapezius muscles. So let's look at the superclav recurrence pattern. So this is the study looking at the 62 patients, 161 superclav node metastases, 44 lymph nodes were recurrence, and the others were presented at a diagnosis, and they were mapped in arterial G volume. So first, the patients with superclav at presentation, 40% of those patients lymph node recurred outside arterial G, and 90% of those patients presented with multiple superclav. So we can see the 3 locations that occurred outside arterial G volume. First, superior to arterial G, so the levels, up to thyroid cartilage. And the second is the lateral low superclav fossa, which is over here. So the orange one is the superclav volume, and this is the lateral that recurs, so outside arterial G. And also the area we call posterior triangle, which is bound by levator scapulae and trapezius muscle. For the patients with recurrence, so 34% recurred outside arterial G volume, 80% of those had no previously radiation, and the patients who had no radiation most recurred at the lateral low superclav and posterior triangle. And for the patients who had radiation before, half of them recurred outside arterial G, which is at superior to arterial G, posterior lateral to the volume, and also posterior triangle. So Brown concluded that we should coverage posterior triangle, the very, very posterior to arterial G volume patient presented with multiple superclav metastases. Study a little bit the same, of 55 patients with superclav metastases, either relapse or initial metastasis. And 30% presented at initial and 70% relapse. And they're mapped or they're contoured lymph nodes in 4 losses: arterial G, MADU, actin, and dichema. And when we look at the CTV coverage, you can see that 80%, the CTV coverage is high when we mapped followed by dichema volumes, and especially at the lateral superclav regions. So 55 patients recurred higher to caudal edge of cricoid bone, so that's superior to arterial volume. And 70 to 90% recurred at lateral posterior to anterior scalene muscle. So it's really here. So it's really posterior to arterial G volume. And it's only contour only by dichema volume. So this study suggested that superclav field should extend posterior to trapezius muscle to cover all those recurred lymph nodes. And again, another study, studying 234 patients, and they mapped in estro and arterial G volumes. Patients mostly were T12 and 03 M0, and the patients had previously radiation. Half of them had regional radiation, 50% of superclav radiation. So green is for arterial G volume, and the blue is for estro. And you can see that most of the patients recurred at lymph node level 4, so in the superclav region. And 88% of those recurred outside SL and inside RTOG, and 20% recurred totally outside RTOG. So let's look where the locations are. So 88.8% that recurred outside SL and inside RTOG, it's happening around here. So outside SL, because SL contour is very small, just 5 milliliters of subclavian vessels. So it's outside SL, but still inside RTOG volume. But remember, SL guidelines say that if patients presented with N3 or local bonds, you should add more margins, like 1 to 2 centimeters. So if we follow that, it's going to cover by SL guidelines. 20% that recurred outside RTOG, its location is at posterolateral to the superclock volume, which is over here. And of those, 70% had at least one regional limb node recurrence other than level 4. And 50% had previous superclock radiation, and half of them previously, initially presented with N2 and N3. So this is what in my practice. Superior border, caudal border, it's an appropriate, caudal border of cricoid cartilage is still the appropriate border for superclock. But if the patient presented with multiple superclock, with N3, it does make sense to add superior more margin to cricoid cartilage. And for the medial border, so SL, I think the lateral edge of, we don't have to include internal carotid artery that we can follow SL. I think this border is appropriate because when we look at the pattern of recurrence, 0% recurred at medial to internal carotid artery. And if we follow to SL guidelines, we can reduce those to thyroid and esophagus. So this is the pattern of the failure. And then you can see that the recurrence pattern mostly recur very posterolateral to superclock regions that draw by RTOG volume. So this is a study from Memorial Sloan Kettering Cancer Center, and they draw and map in SL and RTOG guidelines. The interesting point is they divided superclock into 3 volumes: medial, lateral, and posterior. And the medial and lateral divided by sternocleidomastoid muscle, and the lateral and posterior divided by transverse process. So about 40 to 48% of the patients recurred at medial of the superclock. 5 to 15% recurred at the posterior volumes. 100 of those had grade 3 and 30 patients. And also the 2 superclock recurrence are lymphovascular and nuclear grade 3. So all in all, these patients with initial nodal tumor burden like N2 and N3, patients with pre-existing superclock disease, basically have superclock radiation and tumor characteristic of ER negative, lymphovascular invasion, grade 3 ECE. These patients require much generous coverage of posterolateral to RTOG volume. So these are the recommendations that you can go and look again. So for about XL3, so there is subtle difference among the guides, and current cause either SL or RTOG has the majority of early recurrence. I like to point out of some volumes. For example, interpectoral this is the volume in SL, is in the rectal space, is over here. But that it's already included in Excel level 2, which is the anterior border of Excel level 2. But for Excel level, so the either astro and our majority of 6 are recurrence. But I like to point out of some volumes, for example, the interpectoral lymph nodes, which is in rotor space in astro, and it's already included in axillar level 2. Because for the radcom, the axillar level 2, the anterior border is at the posterior of the pec major, so it's already included interpectoral lymph node. But for RTOG, axial level 2, the anterior border is at the anterior of pec minor, so it's not really included interpectoral lymph nodes. So what I would suggest is you can follow RTOG, but you include interpectoral lymph node as well. Another thing is of the retroclavicular nodes, and you can see that for astro, retroclavicular nodes is included in Excel level 3, which is connected to Superclock volumes, and it's in Superclock volumes over here that included in Superclock and connect to Excel level 3. But for RTOG, there is a gap between Superclock and Excel level 3, and it doesn't include retroclavicular node as well. So what I would suggest is to, extend and to connect Superclock and Excel level 3. For IMN field, this is the boundaries of RTOG. They have cranial and caudal boundaries, the cranial first rib and the caudal of the fourth ribs. So these are the difference of the guidelines. And you can see that for the radcom and astro, the IMN field connect to Superclock fields, which I think that makes sense, and we should do that as well. And the other different thing is that astro has 5 millimeters that extend from the vessels and include all the fast space. So RTOG only the vessels, and the radcom extend, draw all these fat space, and astro as well. When we look at the pattern of failures, most of the patients recurred in the first of 3 intercostal space, and about 10% recurred, below third intercostal space. And also 50% recurred within IMN vessels, and about 20 to 30% recurred medial and lateral to the vessels. So what I would recommend is for the medial and the lateral, you should expand 5 to 5 millimeters from the vessel, and patient risk, we can go to the third intercostal space. But the patients with clinical IMN positive, we also breast and the chest wall. For RTOG, the breast, for early breast, they exclude pec muscle, chest wall, and ribs. But for the locally advanced or the chest wall, they include pec muscle, chest wall muscles, and ribs. So this is only the breast. They exclude ribs and chest wall muscle. But for the locally advanced, they all include here. And the chest. For the radcom, radcom is for locally advanced disease as well. So it doesn't include ribs, but includes chest wall muscles. For astro is for early breast cancer. So it doesn't include ribs and intercostal muscle. And the medial border is at the medial mammary branch from the internal thoracic artery. And for the lateral border of the breast, they use lateral thoracic artery, which is over here. When we look at the pattern of failure, The most common site of failure is the first skin, subcu anterior to pec muscle, which is around here. And the second most common site is at the muscular recurrence within the pec muscle. And you can see that there is no isolated recurrence in intercostal muscles or ribs. So recommendation is the chest wall or the breast posterior border should be at the anterior rib surface, and this breast cancer. So in my practice, T4 or inflammatory breast cancer, I still include ribs and chest wall muscles. This is also the study. They really recommend how to use guidelines. But the original risk, they can use Astro. For high original risk, we can use arterial on the right column. It's possible to include to the fifth intercostal space. So the conclusion of target validation is we use a lot.
Faculty said that she will share the slides with all of us as we have missed some part of it.